Hello, my name is Bridget Palathra. I'm currently the Chief of Palliative Care at Mount Sinai South Nassau. And today's workshop that I'll be presenting today will be regarding palliative care for pulmonary disease, a very important topic in our field. I don't have any financial interest or commercial products or services or other disclosures to mention. Today's learning objectives. Today we'll be going over a good review of respiratory illnesses and palliative care and the concomitant symptoms, specifically dyspnea, that we often encounter. So today we'll define the role of palliative care in advanced lung diseases. We'll also review some pulmonary specific diseases that palliative specialists encounter. And we'll also describe the process and evaluation, treatment, and assessment of dyspnea in the setting of serious illness. In conjunction with management of dyspnea, we'll also briefly discuss some concomitant symptoms such as cough and management of malignant pleural effusions. So just a little bit of background with how palliative care evolved with pulmonary disease. We all know the foundation of palliative care really started with hospice care and our cancer patients and patients that were at end-stage illnesses. Over the course of the development of the specialty, this has expanded to include a lot more chronic illnesses, especially our pulmonary disease patients. And we all know that the ultimate goal in palliative care is to improve quality of life for patients and families. So whether that's at the time of diagnosis, where often our colleagues are involved, non-specialists, throughout the disease trajectory, where we're often introduced to co-manage with our colleagues, as well as at the end of life. It still remains to be an unmet need for many patients with pulmonary disease. And we know, based on a lot of retrospective data, that there's profound impact on patients' function and quality of life, often at the end stages of their illnesses. And this management, because of this, requires a complex interdisciplinary approach that involves a lot of multiple domains. Just briefly, just to guide our conversation, I'm just referring to the clinical practice guidelines for quality care. And we'll go into each domain a little bit more specifically regarding pulmonary disease. What we know regarding the structure and the processes of care, especially when we're delivering palliative care to this population, is that prognostication can be often difficult in our non-cancer disease patients. We often see, which is well illustrated by the graph on the right, how the disease trajectory is often unpredictable and prolonged, and it's often interrupted with life-threatening exacerbations, but with an overall progressive decline. There often comes into the question about when is the best time for primary palliative versus specialty palliative care. And we'll discuss this a little bit more later. Importantly, what we'll discuss even more in depth is about the physical aspects of care. We often encounter the common symptoms of respiratory-related issues such as dyspnea, cough, hemoptysis, and secretions, but often a lot of our patients we also have to keep in mind are often plagued by pain, fatigue, and cachexia. And this is often really related to how there's overlap in conditions in this population. They often do not present with one sole diagnosis, and they often have diagnoses that encompass cancer-specific, non-cancer specific, and also there's overlapping conditions that often are met during their exacerbations when they're often hospitalized. These can include things like pneumonia, pleural effusions, derangements, deconditioning, and ascites. The other thing to take into account, especially when we're managing symptoms with patients with pulmonary disease, is how psychological and psychiatric aspects of care impact our patients. We have to take into account common diagnoses such as anxiety and depression, often being not diagnosed or effectively treated. They often have issues related to the changing character of their illness, often accompanied with insomnia related to their symptoms, adjustment disorders. And this adds to the symptom burden and the suffering in relation to how unclear the prognosis is sometimes early in the trajectory. And again, we also have to take into account these social aspects of care, especially when we're recommending treatments. Often patients are experiencing social biases and stigma when there's relation to smoking related diseases. We have to recognize how it impacts relationships, intimacy, and work for patients, how their change and what they were operating at the time of diagnosis towards the end greatly impacts how their symptom burden is perceived. We also take into account family and caregiver burdens, especially in our older and chronically ill patients, and the greater social isolation that comes with increased symptom burden. We know that pulmonary diseases are more prominent in patients with decreased access to healthcare. We see this also more frequently in patients that are increased environmental exposures and also our older aging population. And also keep in mind, caregivers often have to be involved in multiple respiratory treatments and medication administrations, coordinating oxygen therapy, and often taking patients from multiple specialists to manage a lot of concomitant illnesses. And also keep in mind that the cultural and spiritual, religious, and existential aspects of care of a patient nearing end of life inform the patient and family values, beliefs, and healthcare decisions. So this is always taken into account when we're having goals of care discussions and when we're introduced into the care of these patients. Some signs that values and goals discussions should be had are listed here, and this can be referenced on the slide deck after my presentation. But these are often associated with patients at end stage of their illnesses. And again, the ethical and legal aspects of care. We always are often involved with ongoing advanced care planning and goals of care discussion as the disease progresses and changes. We often talk about resuscitation preferences. At end of life, we're often involved in discussions regarding liberation from advanced technologies like ventilators and palliative extubations. Often we're also coming to see that we're seeing a population of patients that may be lung transplant candidates, and we're often involved in that pivoting of their management. And our patients and also our colleagues often have questions about palliative sedation and mortality, especially towards at the end. So you could see how valued our specialty is in care of these patients. So just to talk about disease-specific conditions, COPD is primarily an illness that we often encounter here in palliative care, especially with advanced COPD. We know that it affects about 5% of the US population and is the fourth leading cause of death. They're often presenting with symptoms of dyspnea, cough, chest tightness, and wheezing. And often for diagnosis, an airflow obstruction and spirometry is required. These patients are recurrently hospitalized to the hospital as well as the ICUs, and this can contribute to patient and healthcare costs. And the thing to keep in mind, prognosis is difficult in this population because of the variable disease trajectory and the inability to predict end of life. It makes it very difficult to engage about advanced care planning in our patients. We have a BOAT index, which involves multiple factors, including BMI, FEV1, as well as MMRC, dyspnea scale, as well as the 6-minute walk test, which helps predict mortality from respiratory disease, as far as a 4-year survival, and it's predictive of all cause and respiratory mortality in this setting. But what we do know is universal factors associated with more than 50% of 6-month mortality is often related to poor performance status, advanced age, malnutrition, comorbidities, organ dysfunction, and hospitalization for acute decompensation. The other thing to also keep in mind is COPD, like I mentioned earlier, overlaps with a lot of other multiple medical conditions. There's often systemic inflammation associated with a lot of chronic comorbid conditions, which increases the morbidity and mortality. Some of these factors include metabolic syndrome, systemic inflammation, hormonal imbalance, hypoxia, weight loss, skeletal muscle weakness with limb muscle dysfunction, anxiety, and depression. And with these medical comorbidities like anemia, CAD, hypertension, CHF, GERD, and osteoporosis, this can make it even more complicated and make prognostication a little bit more challenging. And also keep in mind, COPD can overlap with other chronic lung diseases like asthma, bronchiectasis, interstitial lung disease, lung cancer, and obstructive sleep apnea. What we do know is they're all associated with increased symptom burdens, and it affects clinical outcomes very negatively for these patients. An important thing to keep in mind for our patients with COPD are the acute exacerbations. And this is when their symptoms are worsening, often the dyspnea and the cough, where they're having like excessive sputum production. This is often related to infection and environmental factors. But what we do know is acute exacerbations, along with increasing symptom burden, it contributes to decreasing the lung function with each exacerbation, poor health status and quality of life, increased hospitalization and risk of rehospitalizations, and also a higher risk of COPD progression and mortality. Unfortunately, COPD symptoms and burden are underevaluated and poorly addressed when compared to lung cancer. Even with using treatments like bronchodilator therapy, daily symptom burden is high and often not systemically or effectively addressed in this patient population. COPD patients also have greater symptoms, including breathlessness and anxiety, and lower rates of complete relief of these symptoms during the last week of life versus patients with cancer. And what we find is medication use for comfort, for symptom relief is lower in this population compared to cancer. Now, to touch base a little bit on interstitial lung disease, I'm not going to go into too many details, but what we do have to keep in mind, this is a population that we do encounter frequently. And it's a heterogeneous group, and it's related to the expansion of the interstitial compartment of the lung by fibrosis. It can be caused by inflammation as well, or both of these factors. Often the terms that we often encounter are idiopathic interstitial pneumonias or idiopathic pulmonary fibrosis. But also keep in mind there are secondary causes, often related to connective tissue disorders, occupational exposures, chronic hypersensitivity pneumonitis, as well as medications that might induce this state. And also keep in mind there's some less common etiologies such as sarcoidosis and rare forms of ILDs. Again, there's a constellation of symptoms that are pulmonary related in this population. Patients often complain of cough, dyspnea, and fatigue. And again, it's an unpredictable disease trajectory. The treatment at baseline involves treating the underlying cause and can include a combination of immunosuppressive therapy and corticosteroids. What we do know about interstitial pulmonary fibrosis is that it can have a median life expectancy of 3 to 5 years from the time of diagnosis. There's a changing landscape in regards to treatments for ILDs with newer agents, primarily for interstitial pulmonary fibrosis. We find some of these agents actually reduce the rate of lung function decline and offer some longer survival. And it also reduces the rates of exacerbation, which can cause morbidity and mortality in this population. But unfortunately, it does not reverse the disease or prevent the decline from occurring. It's not associated with decreased pulmonary symptoms or improved quality of life, unfortunately. And what we do know is that it's now being used for some other ILD conditions aside from interstitial pulmonary fibrosis. And keep in mind, this population also requires a multidisciplinary approach due to the progressive nature of the illness, the high symptom burdens, and the reduced quality of life. These patients often experience a lot of side effects from their medications and often develop frailty as the disease progresses. They also have overlapping illnesses like cardiac disease, hypertension, emphysema, and sleep disorders, which impact quality and quantity of life. What we do know is once they develop chronic hypoxemic failure requiring long-term oxygen therapy, the mean survival is approximately at 8.4 months. And we often are involved when transplant is being considered. Pulmonary hypertension is another disease entity we encounter as well, and it is often primary or resultant of other comorbid conditions, as I'll describe. And it's characterized by a progressive increase in the pulmonary vasculature resistance, the PVR, resulting in right ventricular failure. What we do know is the median survival without treatment is about 3 years, and with treatment is 7 years. So there is a limited prognosis in this population, even with treatment. The clinical course is variable, and it depends on the type, the functional class, and the associated comorbidities the patient might have. They are often requiring a lot of targeted therapies if they're deemed to be candidates. So this often involves our involvement with our pulmonary and cardiology colleagues in managing and co-managing these patients. A lot of these therapies can improve dyspnea, exercise capacity, functional class, as well as quality of life. And keep in mind, different populations respond differently to different treatments. The WHO has a classification that's divided into 5 categories. Most commonly, what we encounter is group 1, which in itself is a rare disease, 5 to 15 persons per 1 million adults. These patients tend to be younger and they tend to be female. There are better treatment opportunities, but what we do know is when the patients do get hospitalized and when patients are at end of life, when they are provided these treatments early on, these this can be impacted. With the treatment of pulmonary arterial hypertension, there's still a high mortality risk. Overall, 5-year survival is about 65%. Factors that are often associated with poor prognosis include male sex, people over the age of 50, poor response to vasodilator therapy, and right ventricular failure. And then there's other subcategories, including group 2, which is related to chronic lung disease. This also has a poor prognosis. The 5-year survival is 38%. Group 3 has a similar life expectancy as patients in type 1, and this is often related to cardiac-related diseases, which can often be addressed earlier on with interventions. Group 4 is often due to some form of obstruction of the pulmonary artery, like chronic thromboembolism. So it requires treatment of the underlying etiology, but may not affect the overall trajectory and prognosis. And then group 5, it's a class of patients with unclear or multifactorial mechanisms causing this. Patients, again, commonly present with the constellation of dyspnea, fatigue, and exercise limitation. Our group 2 and group 3 patients also present with symptoms of chronic lung and cardiovascular disease, which makes management a little bit more challenging. The progression marked by heart failure, often patients present with exertional chest pain, pre-syncope, syncope, or even passive hepatic congestion and ascites. They often experience abdominal pain and decreased appetite because of that. They are often provided supportive care with oxygen, diuresis, and opiates, especially closer towards the end of life. And pulmonary rehabilitation can improve exercise capacity and quality of life if patients are able to engage in it. Often the primary cause of death is due to right ventricular failure, often acutely related to anesthesia, infections, volume depletion, or if there's any pause in the vasodilator therapy that they're on. Cystic fibrosis, this is, although rare, it's becoming a more prevalent population, especially in adult palliative care. We're finding a lot of patients are transitioning from their pediatric providers to adult providers with this disease population. And this is related to the CFTR protein, and it's a hereditary disorder. What we find is there's impaired ion transport across the epithelial cells, specifically in areas like the sinus, the lung, and the pancreas, which often induces a lot of the symptoms the patients present with. There are some modulator therapies that are available and have shown to improve outcomes in childhood, which is why a lot of these patients make it into adulthood. Decreased life expectancy in this population is often related to the progression of bronchiectasis, the recurrence of pulmonary infections, and often patients die because of respiratory failure. They often have symptom burden related to their sinus illness, chronic daily cough. They often have excessive volumes of sputum. They develop exocrine and endocrine related issues from pancreatic insufficiency and weight loss. What we do know is that insulin-dependent diabetes as well as Pseudomonas infections are linked to ongoing loss of lung function. And mortality and weight loss are associated with decreasing FEV1 measurements as the disease progresses. And a small note on CLAD, or chronic lung allograft dysfunction. We're finding that, we are finding that we have populations that are surviving and may be eligible for lung transplant depending on their primary diagnosis, and can be curative for conditions like interstitial pulmonary fibrosis or pulmonary artery hypertension, depending on the condition. Post-transplant, often the median life expectancy is 6.7 years, which still warrants our involvement in their care. We find an increase in morbidity and mortality in more than 50% of recipients at 5 years. And more than 75% of survivors at 10 years post-transplant. And again, these patients will present with the same similar constellation that I was discussing earlier, which includes dyspnea, cough, and progressive respiratory failure. So we talked a lot about chronic illnesses and the approaches to care, and a common theme that often arose was the concept of dyspnea, which is what a lot of and most of our patients with pulmonary disease do present with. So what does dyspnea mean to our patients? And what I find as a provider and working in palliative care and also as an internist is how differently patients will present and express how they feel short of breath. It may not be the typical, I can't catch my breath. It may not be the typical, I can't breathe. So often patients may describe it as chest tightness, tiredness, suffocating, or unable to get enough air. choking at some points. So let's be a little bit more clear about what the clinical diagnoses are for dyspnea. And, I think what we do know is dyspnea is breathing that's perceived to be difficult or burdensome for the patient. So it's a self-reported symptom. It's not just an acute one-dimensional symptom, it's often complex as the disease progresses. We have new onset dyspnea, which is often acute and it presents abruptly. And this often resolves. This might be in a situation where a patient might have an acute bronchitis. Chronic breathlessness syndrome, on the other hand, this is what we see in our patients with chronic lung disease, and it's persistent breathlessness despite optimal treatment of the pathology, and it can be disabling for this population. And then what we often see in a hospice setting or even in the hospital are dyspnea crises, which often occur in the later phase of the disease towards the end of the trajectory. And these are sustained and severe resting symptoms and discomfort for breathing. This is often when patients have advanced, often life-limiting illness, and it overwhelms not just the patient and the caregivers, but it can also overwhelm providers that are helping to achieve good symptom relief for these patients. So let's take a break and I'll ask a quick question based on what we just reviewed. True or false? Total dyspnea is a concept that describes the synergistic effects of physical, psychological, social, and spiritual factors on a patient's breathlessness experience. And we'll say that's true. Total dyspnea is a patient's perception of dyspnea, and it's complex, very similar to how the concept of total pain. And what we do know, there's multiple synergistic effects of factors on the breathlessness experience for our patients. Often there's the direct physiological effects of having the lung disease and the concomitant comorbidities. Psychologically, a lot of our patients experience anxiety and depression. Our patients also experience a lot of social isolation, and there's distress for caregivers and clinicians caring for this patient. And a lot of our patients at the end of their trajectory are experiencing existential crisis and coming to face with their mortality. So question, in dementia patients, the prevalence of dyspnea breathlessness is as high as 1%, 7%, 12%, or greater than 50%. So the answer is D, greater than 50%, which, in itself, I also found surprising. But they've actually done reviews on the prevalence of dyspnea and serious illness, and it's not just isolated to lung cancer and cancer patients. We see it in cardiac disease as well as end-stage renal disease. We see it in dementia patients towards the end of their trajectory because of the overlap of comorbidities and concomitant illnesses these patients experience. We see it with our AIDS patients, as well as with their neuromuscular disorders like ALS. And we also see this in stroke patients. Question. A 45-year-old man recently immigrated from India with a newly diagnosed metastatic non-small cell lung cancer is admitted for acute hypoxic respiratory failure. He has no previous medical history and has recently been started on oncologic directed therapy. He's awake and alert, but complains of having heavy breathing. He's febrile on high flow oxygen. His blood pressure is 140/90, heart rate of 100, respiratory rate of 20, oxygen saturation is 94%, has bilateral crackles on auscultation, but no rhonchi. What factors could be contributing to his dyspnea? So again, when we try to manage dyspnea, we're always looking to evaluate what the etiology is. And like I mentioned on an earlier slide, they may be specific to cancer or non-cancer conditions, but also keep in mind there's often overlapping conditions, and patients may be experiencing the spectrum of these comorbid conditions depending on their diagnoses. Another important thing I think we should review is what contributes to the sensation of dyspnea, because it helps address how we approach symptom management. What we do know about dyspnea and the pathophysiology of it is there's direct associations to specific neural mechanisms. These all relate to work of breathing, air hunger, and chest tightness. Of course, with work of breathing, what we know fundamentally, there's often an increased effort of respiration. We also know that there are respiratory muscle afferent signals that go to the cerebral cortex. And these can be often impacted by increased resistance due to airway obstruction or external restriction, or this may be related to muscle weakness. This could be due to a neuromuscular disorder, cachexia, or deconditioning. Air hunger, on the other hand, is often described as an unsatisfied inspiration. And this is often related because there's chemoreceptor activation. We know that there are receptors that are in the medullary area, which are sensitive to hypercapnia. And we also know there's hypoxemic receptors in the carotid and the aorta, which can help also trigger this neural mechanism. Often what we find is that there's a mismatch that occurs for what the cortex receives these signals from these centers. And what happens is that the respiratory response is often not adequate, which often exacerbates and cycles this air hunger sensation. Chest tightness, we often see this associated with bronchoconstriction, and it's related to airway receptors that we find in the pulmonary afferents, which go directly to the brain. And often there's a neuromechanical dissociation, like I mentioned. So there's a disruption of these neural connectivities between the peripheral areas in the brain. And these are often stimulated from work of breathing or chemoreceptor stimulus. So question, a 60-year-old woman with newly diagnosed lung cancer is admitted for pneumonia and acute hypoxic respiratory failure. She has no previous medical history and takes no medications. She's awake and alert, but complains of having heavy breathing. Pulmonary embolism has been excluded. She has multilobar infiltrates without effusions and no bronchial obstructions on imaging. She's on high flow oxygen. Blood pressure is 140/90, heart rate of 100, respiratory of 20, oxygen saturation is 94%. Has bilateral crackles on auscultation, but no rhonchi. She's been started on appropriate antimicrobial therapy. Which of the following would not be appropriate in the acute management of this patient's dyspnea? A, morphine, 2 milligrams IV Q3, 8 hours PRN, shortness of breath. B, handheld fan therapy. C, fentanyl, 12 microgram patch, Q72 hours. D, assessment of anxiety. E, discussion of resuscitation and intubation preferences. So the answer here, what would not be inappropriate would be this long-acting opiate. And we'll discuss a little bit more about why. So to evaluate someone's dyspnea helps with assessing what's causing the dyspnea and how to approach the management. So to guide diagnosis and treatment, we need to clarify whether this is new, whether this is an ongoing process like chronic breathlessness, or is this an acute or chronic process, like a dyspnea crisis at end of life. Some scales that are often utilized for assessing dyspnea that are patient-reported include the ESAS, which we frequently encounter, the Edmonton Symptom Assessment System. And this also helps to assess for any concomitant symptoms like pain, nausea, depression, anxiety, drowsiness, appetite, and sensation of well-being, which may impact how we approach treatment. And to keep in mind that we are doing this continuously and repeated throughout the disease course, and that what holds true early on in the disease trajectory may not hold true towards the end. And the management may need ongoing titration and modification as the disease progresses. It's important to incorporate that total dyspnea perspective for patients and families and caregivers. And also keep in mind, like I mentioned before, breathlessness is distressing for both reporters and observers, including us. So the management involves shared decision-making model, which is vital at the disease trajectory. In the setting of a new disease process or a change in chronic illness or a presentation of hypoxemia, it's important to treat the underlying causes and potentially involving specialty consult, depending on what the diagnosis is and where the patient is. It's also important to weigh in serious illness factors, whether there are benefits or risks to any specific diagnostic or therapeutic interventions, and is the care that we're providing concordant with the patient's values and preference and providing an acceptable quality of life. And when disease-directed therapy does not impact on the sensation of dyspnea and advanced illness, then we can focus on more symptomatic relief. So some non-pharmacological approaches that are easy to utilize and do not cause any harm could include things like positioning, like in COPD patients, having them lean forward with pursed lip breathing. Sometimes in pleural effusion, we can have patients lie on the affected lung to help aerate the unaffected lung to improve dyspnea symptoms. Fan therapy, which has been studied to a limited effect, may alleviate dyspnea. We recommend them as they're inexpensive, low risk, and the patient may benefit from a trial. Pulmonary rehab has been shown to have a clear benefit in COPD patients who can undergo the process. We're not speaking about our patients that are bedbound, homebound, that have been coming in from multiple exacerbations. These are patients that have pretty good baseline functional status and can undergo the process. We know that rehab does improve dyspnea and fatigue, quality of life, and exercise tolerance in this population. Hospital-based programs tend to have better outcomes versus community-based ones. But in patients with limited life expectancy, the benefit is not known. Some other non-pharmacological interventions can include breathing training, walking aids, neuroelectrical muscle stimulation, chest wall vibration, and there's some evidence that may support acupuncture or acupressure. Another important factor to take into account is managing concomitant symptoms. An often symptom that we often encounter is chronic or refractory cough. I'm not speaking to acute cough. I'm speaking to patients that have had cough for weeks, and this is often related to their chronic illness or downstream effects of treatments. The recommendation is always to start by treating the etiology, whether there's an infection, a medication side effect, perhaps radiation effects. We find cough suppressants can be helpful, but not a lot of evidence supporting regarding locally acting agents like guaifenesin, which helps reduce the thickness of the secretions and the volume of the secretions. There are some neural-mediated agents that you can utilize, like peripherally acting benzoate. Again, no significant evidence supporting it. Then there's, of course, centrally acting agents like opiates and dextromethorphan. What we do know for refractory cough and chronic cough, systemic opiates are often the drug of choice, and we know codeine is not superior. And there's some emerging evidence that suggests that maybe gabapentin may have a role in chronic refractory cough. Another factor we may come across is our patients with cancers is malignant effusions that may contribute to dyspnea. Some patients may have asymptomatic effusions, but some patients might develop increasing infusions and with their comorbid conditions develop worsening symptoms like dyspnea. So it's important to take into account prognosis, how quickly the effusion reaccumulates after it's drained, and the functional status of the patient. Traditionally, it would be most appropriate to address with systemic cancer treatment based on the patient's expected trajectory. If we have a patient that has expected prognosis that's very good, what we're talking about months to years, and it may be appropriate to use systemic therapy versus someone that we may think may be in dying process where it would not be beneficial. Thoracentesis may be an opportunity for this population with a poorer prognosis because it's relatively a simple procedure. This works better for patients that have slower accumulating effusions versus patients that might have more quickly reaccumulating effusions. Pleural catheters are the preferred, especially patients with intermediate prognosis. They're known to improve quality of life. They're also useful for patients with entrapped lungs where there's constant refilling of the pleural space. Patients that are often provided pleural catheters often have shorter lengths of stay in the hospital, but it's important to pay attention to care coordination and transitions and ensuring that there's a good process for the patient when they leave the hospital to manage these catheters. Pleurodesis could potentially be an option as well. And it should be reserved for more of our patients with better prognoses of more than 6 months and a good performance status. Oxygen therapy. I think this is a very important topic because I think it's something that we often try to help address for a lot of our patients, whether in the hospital or in the hospice setting. What we do know is that we recommend it for resting or exertional hypoxemia. There was an international double-blind RCT that examined oxygen versus pressurized room air in patients with life-limiting illness and refractory dyspnea, and noted to be hypoxemic on blood tests. And we found that dyspnea improved comparably in both arms. And what we attributed to is potentially is air stimulating the nasal passage has likely reduced the sensation of breathlessness. Subsequent systematic reviews found oxygen in non-hypoxemic patients helped improve in patients with COPD, but not necessarily in cancer. The recommendation is for dyspneic non-hypoxemic cancer patients, they should be assessed for opiates or fan therapy before consideration of oxygen. We also find there are higher levels of oxygen therapy that are often provided, mostly in a hospitalized setting, high flow oxygen. This often limits where the patient is often able to transition to, although we're finding that there are hospice agencies that are utilizing home equipment that can help provide this level of care at home. It makes communication and oral intake easier for the patients as well. Non-invasive ventilation or our BiPAPs or our non-invasive positive pressure ventilation modalities. We find they utilize throughout the trajectory of the pulmonary disease, but more frequently toward the end. We recommend time-limited trials that are appropriate, achievable, patient-centered, and short-term goals in the setting of end of life. We found in a prospective study that in over half of the patients at end of life, it did not affect quality of life and did not provide significant dyspnea relief. But there may be a reasoning behind it, perhaps a bridge to a relative coming or making a specific date. There is also noted benefit in some specific conditions to use non-invasive ventilation chronically, such as ALS or neuromuscular disorders, or COPD patients who often may use it nocturnally, and also in our CHF patients when they're hospitalized for diuresis. Now that we've gone through a lot of the non-opiate management, I'd like to draw our attention to how we use opiates in dyspnea and what the evidence is. And what we do know is when disease-directed therapy is limited, we have existing evidence and expert societies supporting the use of oral and parenteral opiates for dyspnea and advanced illness with chronic breathlessness and acute dyspnea crisis. And it can also be beneficial early in the disease trajectory, improving quality of life and functional goals based on what the cause of the dyspnea is. And again, as we reviewed in the etiology and the pathophysiology, it's important to remember that dyspnea relief is theorized due to how opiates act, mechanism action. We know that it affects central opiate receptors, so there's direct cortical opiate receptors, as well as indirect, the correlated discharge from the respiratory center to the sensory cortex, as well as the peripheral opiate receptors in the respiratory tract. We also know it also helps alleviate anxiety to some extent as well. As far as safety, we know with advanced cancer, COPD, and ILD patients, there's no concern of induced mortality, respiratory side effects if it's managed responsibly. Chronic dyspnea patients, long-acting morphine has been found to be beneficial and safe. Keep in mind, these studies did leave out chronic hypercarbic patients, sorry. There may be a benefit for ALS patients. CHF is not completely clear, although it has to be a discussion and review of what the concomitant illnesses are. So informed decision-making and ongoing counseling is very important. It's also important to inform about common side effects like constipation, nausea, somnolence, and hallucinations. And this reference is just to look at what starting doses for opiates would be for opiate naive patients, and depending on what the cause of the dyspnea is. And again, what this highlights is if we're having episodic or acute dyspnea, the mainstay is to utilize short-acting opiates initially, and to start at a very low dose and go slow and see what the patient requires. Again, there is no specific superior opiate, but a lot of the studies have been utilized using morphine. Chronic dyspnea, on the other hand, we do have data that does support with our chronic dyspnea patients that extended release morphine, 10 to 20 milligrams PO daily, is very helpful as a starting dose. Keep in mind, with the current opiate epidemic climate, it inhibits opiate use due to the recent CDC guidelines. And these guidelines often refer to chronic pain, but keep in mind they don't apply to our patients being managed for palliative needs, end of life, and hospice settings. It's still, though, important to risk stratify patients for substance use disorder, addiction, diversion, and to monitor for misuse when we're managing these patients as such. And it's always important to follow the local state laws and national guidelines for your practice. Non-opiate medications like nebulized medications, benzodiazepines, and buspirone um, have not been shown to be effective in alleviating symptoms based on evidence. Specifically with benzodiazepines, it does not support its use in dyspnea. We find it to be more sedating than morphine. Um, Sometimes, in some cases, if opiates fails, we may consider benzodiazepine as an alternate or an additional treatment. Corticosteroids, um, we use them frequently in our patients, especially our COPD and ILD patients, as it's clearly defined in their disease management. We also use it in a lot of cancer-related conditions, like any sort of treatment-induced pneumonitis, like radiation or drug-induced pneumonitis. Patients are experiencing supravenous cable syndrome. It's important to monitor patients for delirium, and they often can have side effects at high doses, like psychomotor agitation, hyperglycemia, and fluid retention. So it's important to have an intentional plan as far as the dosing and the length of treatment that you intend to utilize it for. Palliative sedation, it's used in rare instances when all other measures that we've just discussed don't improve the dyspnea, and when we're experiencing someone really at the end of life. And keep in mind that this involves a really intense shared decision-making process between providers, patients, and families. It's important to know that and understand that patients and families understand that this is about how to keep someone comfortable at the end of life and to ensure that this is aligned with their care goals. It's recommended to only be performed by clinicians who are trained and experienced, and we often use a benzodiazepine infusion in these settings. We don't have any conclusive data regarding antidepressants, herbal medications, or cannabinoids in dyspnea, unfortunately. And keep in mind, we spoke a lot about the treatment of dyspnea, its presentation, but what it actually means independently. The presence of dyspnea is a risk factor for overall mortality, independent of age, smoking history, and lung function. And it's associated with shortened survival in multiple conditions like advanced cancer, COPD, ILD, and cardiac disease. So important takeaway points. Advanced lung disease requires palliative care from the time of diagnosis. Basic management is within the scope of primary palliative care, our non-palliative providers, and they can escalate it to us as appropriate. Dyspnea and breathlessness is a common symptom in serious illness, both cancer and non-malignant conditions. Advanced lung disease exerts a significant psychological, social, existential, and spiritual impact on the patient's experience, as well as their symptom burdens. Treating respiratory symptoms require pharmacologic and non-pharmacologic approaches, as we've reviewed. Opiates play an important role in relieving dyspnea and cough in patients with advanced illness and should be considered alongside disease-directed therapies. Future research focused on palliative management of respiratory symptoms is really needed to inform practice guidelines for various respiratory conditions. Thank you again, and please reach out if you have any questions.